Good morning. I'd like to call this meeting of the Community and Health Services Committee to order for September the 9th. As we enter the month of September, I'd like to acknowledge several days of significance. September the 11th is Enkotasha, which marks the beginning of the Ethiopian New Year and is celebrated with religious ceremonies, cultural events, and family gatherings, symbolizing renewal and hope for the future. From September the 14th to the 20th is Mennonite Heritage Week, which celebrates the rich history and contributions of the Mennonite community in Canada, offering an opportunity to reflect on their values of peace, community, and service. And September the 16th to the 23rd is Bisexual Awareness Week, and Bi Visibility Day is September the 23rd. This week celebrates bisexuality and promotes understanding and acceptance of the challenges faced by bisexual individuals. Today, we're going to be hearing from three delegations, actually, one discussing simple smart childcare as it relates to the Canada-wide Early Learning Childcare Plan, and other discussing a public camping bylaw. We will also hear a presentation from staff on the Paramedic Services Master Plan for 26 to 2035. I'd like to begin by inviting Julie Hale, Committee Clerk, to conduct the roll call.
Thank you. Regional Chair Redmond.
Present.
Councillor Craig.
Present.
Chair Erb.
Present.
Councillor Foxon.
Present.
Councillor Gowing.
Present.
Councillor Harris.
Present.
Councillor Hunick.
Good morning, everyone.
Morning. Councillor James.
Present.
Councillor Liggett.
Present.
Councillor McKay will be joining us later. Councillor Nowak. Councillor Rodriguez.
Present.
Councillor Salonen will be also joining us later. Councillor Shantz.
Present.
Councillor Ripavanovich. And Councillor Wolf.
Present.
Thank you.
Julie, I am present. I'm just online.
Oh, my apologies.
As we begin this meeting, we are again reminded that many of our homes and places of employment in Waterloo region are situated on the land that is the traditional territory of the Haudenosaunee, the Anishinaabe, and Shinnecoin peoples. We recognize and deeply appreciate their historical connection to Waterloo region, and we also recognize the contributions Indigenous peoples have made in shaping and strengthening this community. We are grateful for the opportunity to live and work here and reaffirm our collective commitment to keep the promise that reconciliation takes place through learning and community building with the Indigenous people who continue to live here. We are all treaty people with the responsibility to honor all of our relations. Are there any declarations of conflict of interest under the Municipal Conflict of Interest Act? None. We have no presentations. We will move into our delegations, and before we begin, I'd like to remind delegates, whether you're in person or online, that some general reminders. Interrupting councilors or staff or other delegations are not tolerated. Derogatory statements about councilors, staff, or other members, and hate speech or defamatory comments. And one last reminder for delegations, please do not take offense if following your presentation there are no questions from council. This is council's time to really listen and reflect upon the opinions and ideas shared with us from our community members. As a quick reminder to the members of the audience, you are asked to maintain order, and this means that you do not address the committee without the permission of the chair, interrupt anyone, disrupt the meeting with unreasonable noise or vocal expression such as applause, booing, or cheering, or display signs or posters. We have delegations here representing Simple Smart Childcare, and I'd like to invite Bina Shadhai and Parth Chowdhury to come and address council. Would you please come to the podium, and you have 5 minutes. Welcome. I don't think your mic is on.
Sorry about that. Good morning, everybody. My name is Bina, and I operate Simply Smart Childcare Center in Breslau. Some of our parents are joining us virtually today. I would like to thank you for the opportunity to speak about the Canada-wide Early Learning and Childcare Program, better known as CVAC or the $10 a day program, and why families at Simply Smart Breslau must be included. My intention today is not to undermine the work that has been already done, but to show this from parents' perspective or families' perspective. For over a year, while families in other daycares have benefited from reduced fees, families at our center have continued to pay full fees with no relief in sight. This is despite the fact that Breslau was identified as a priority growth area when we applied for CVAC last year. Caring for a child is a journey. By the time baby turns 11 months, parents are preparing to return to work and looking for a quality, affordable childcare. When families tour our center, they are thrilled to find a space. With 13,400 children on the regional wait list, finding a space feels like a dream. But then comes the shock. Their child will not be eligible for the reduced fees. Parents see the program on the news, they hear it from the friends and families. Yet I am the one who has to tell them they must still pay full fees. Their first question is always, why not here, why not my child? And there is no good answer. Our CVAC application was denied in 2024, citing limited public transit access and that our location was not a top-ranked priority area. In 2023, the Children's Services identified Breslau Woolwich as the second highest priority area for the new childcare spaces. But by 2024, it had dropped to 11th and was later removed from the priority list entirely. The Children's Services have mentioned that the target is met for the area, likely because a new school with 86 spaces is planned. The problem, the school is not open and may not be for another year or two. Families need relief today. Counting future spaces as if they exist now goes against the purpose of CVAC, which is to provide immediate affordability. Meanwhile, Simply Smart Breslau is already open, licensed, and serving families, but excluded from CVAC. This exclusion is a part of a bigger issue, is how CVAC has been implemented in our region. Centers like ours ready to serve families today were left out, while projects 18 to 24 months away were counted towards targets. Out of 3725 new spaces approved since 2023, about 559 should have been allocated for profit providers under the provincial 85-15 ratio rule. Instead, only 284 were allocated. By April 2025, our region allocated an additional 411 spaces, bringing the total numbers to 4,136 spaces. Of this, 2,419 are operational, while 1,717 are allocated to become operational by December 2026. Importantly, 1,306 of these spaces were part of the 2023-2024 allocation or request for proposal process and were required to open by December 2025, as per the eligibility criteria. That deadline has now been extended to December 2026. Meanwhile, our operational center is excluded. Reserving funds for future spaces while families today pay unaffordable fees is not fair and is not in the best interest of children. Other regions have taken more balanced approach. For example, some requires that once center is approved for CVAC, space must be open within 120 days.
Excuse me for interrupting. You have 1 minute left.
Thank you. This ensures immediate relief while still planning for the future. Why this matters? The purpose of CVAC is simple: affordable quality childcare today and planning for tomorrow. But in our region, families are being asked to wait until 2026 while spaces like Simply Smart Breslau are ready right now. My request is simple: include Simply Smart Breslau in CVAC immediately. Doing so, this will deliver immediate relief for families at our center and restore fairness and trust in how CVAC is delivered. This is not just a technical policy issue. It is about equity, fairness, and urgency. Every day that family continues to pay full fees is another day the promise of CVAC is broken. Once again, I would like to thank you for the opportunity as well as Children's Services Department to provide requested information. Thank you.
Thank you. If you would just like to remain there, there is a question. Councillor Hunick?
Thank you. Through the chair. I'm not so much a question, but a comment. I wanted to thank you for coming today and express that I'm a little bit heartbroken that the province doesn't offer us more Seawalk spots to offer you. So I think the issue here is that we need more provincial funding to come through for this program to be as successful as it should be. Thanks.
Thank you.
Councillor Shantz?
Thank you. Thank you for coming in today and showing me through your center yesterday. It's a beautiful facility, and I appreciate the programming that you're offering there. So my question is, it may be a little bit personal, but why did you decide to open knowing that there was a chance you wouldn't get the CWELC funding?
So our decision, there were a couple of things why we opened without, of course, there was no guarantee of CVAC. One of the reason would be is that there is another location in region of Waterloo which had a long wait list back in 2023. That's when we started exploring other options, is that what can be done. And then we found the property where we were interested, not property, I should say, the place where we were interested. And in 2023, as I mentioned, that Breslau was part of the priority growth. And we had communicated with these children services when we started construction. So those two had gone together. First was demand and being in the priority growth. Second thing, CVAC, yes, it's important for families, and that's the reason why we are here. But that's not the only reason why we have go ahead and opened this center in the community. We have done this this is our second location as an owner. We see the difference it makes in a kid's life. It's a magical from infant to preschool and then they graduate. So that was the one of biggest and strong reason for us to go for another location. But as I said, that we saw that there was opportunity here in the priority growth area, even though, of course, by the time when we applied, it was at 11th rank, but there was still opportunity for, it was under the priority growth for families to get benefited from the program.
Okay, thanks.
Councillor Verbannik?
Thank you, and thank you to the delegation for coming in. Mr. Chair, I'm wondering when would be the appropriate time to ask staff some questions, as this item isn't on the agenda beyond the delegation.
Why don't I check to see if there's other questions from council members first, and then I'll ask. Any
Thank
other
you.
council members?
Just for staff.
Pardon?
For staff.
For staff, yeah. Okay, why don't you go ahead?
Thank you very much, Chair. So I guess my first question for staff on this is, how does money flow in this program? Does it flow directly to the provider from the upper orders of government, or does it flow to us and then we flow it through to the providers that we approve?
Thank you for the question. It's the latter, Councillor Urbanovic. The money flows from the province through the CWELC program, the province and the feds, but it comes through the Ministry of Education, and then we fund it to operators directly.
Okay, and so in terms of the dollars that have been allocated to us right now, do those dollars flow automatically, and so therefore they're sitting in an account until the people we approve actually open up, or do they flow in some other mechanism?
Sorry, I'm just looking to Barb Cardo.
Yeah,
Do you want to?
they flow automatically. There are
Come on down.
Yes, they flow automatically. There is an allocation for each year that flows, and we are required to remain within the budget in each calendar year.
So I guess the question is, if there's projects that have been approved going forward, but it's going to take time for them to build, but we've already received the money for them. What's happening with those dollars?
The capital dollars carry forward.
Okay, just the capital ones, but what about in terms of the operating dollars?
And the operating dollars do get spent within the calendar year. We only receive the amount of operating funding that we have secured.
In terms of spaces that have actually opened up?
That's correct.
So I guess, are we, by waiting, we have these unutilized spaces that aren't operating. Are we leaving money on the table with the provincial and federal government in the meantime while we wait for these spots that may open 6 months, 9 months, 12 months from now? So they've been approved, the capital dollars sit in our account, the operating dollars, if I understand your explanation correctly, are being left on the table with the province and the feds as opposed to with ratepayers in our community.
I'm going to have to come back to you with a very clear answer about that, but we are allocated funding within our space targets for each year. So in 2025, we receive enough funding to grow a certain number of spaces in 2025. And then 2026, that allows for, we get enough funding to allocate to the existing program or the new programs that are opening in 2026. There could be some delays that happen, but I don't have those exact figures because it is just so dynamic. In terms of leaving money on the table, I would expect very little is left on the table or has to go back to the province because we are able to expend our allocation within the calendar year. In terms of if I could just speak to the intent of the program is to grow in the most underserved communities first. It's because we, as you know, we have childcare deserts. And so what the province has asked us to do is make sure we take care of those childcare deserts. And Kitchener is an example of a location with a lot of deserts. And so we're asked to take that location, take the time that is needed to grow those spaces in the Kitchener area and not just fill wherever spaces happen to come up. And so we have really focused in this last year and next year on those priority areas, those highest priority areas.
Okay, there's other questions I'll come back and bring in again, Mr. Chair. Thank you.
Councillor McCabe.
Thank you very much. It is a question for staff, just to understand how if you could remind us how the funding for this works. My understanding is, this is primarily funded by the federal government. It flows through the province, but in our and then comes to the region for us to manage, as you just described. My understanding is that in other provinces, the provincial governments match or nearly match the federal funding, but that's not the case in Ontario. Is that correct?
I don't know if that is correct, but the province was required to continue to fund at the levels they were already funding childcare, and that would have been in their agreement. I can't speak specifically to what those ratios are in the province of Ontario, but I
think that would be really helpful to know if we could get that information, because I fully can appreciate the situation that the delegate was describing and other delegates and people who operate daycare, childcare centers are describing. But I'm concerned about, it feels like, the region is being sort of held to account for something that's not fully within our scope of funding, right? Like, this is a federal program, and I would like to understand how much provincial dollars go in, because my understanding is in other provinces, other provincial governments match it, which then, of course, enables us to open more spaces locally. And So I'd just like to understand how that works and maybe, where we need to talk to the province to say they need to step up their game so that we can, so agencies like the one that was just presenting, we can support more child and reduce the amount of childcare deserts across our community.
We have, there's two more council members, Councilor Shantz and Councilor Urbanovic, wanting to speak. However, I'm wondering if some of the questions you were asking, Councilor Urbanovic, if some of these other questions are related to getting some more information that would be brought back, that would help clarify some of these questions. And so I'm not sure if Councilor Shantz and Councilor Urbanovic, if it's related to that, or are there other new questions? Councilor Shantz.
Thank you. It's a new question, but it's related to the statistics, and so I'm not sure if Barb can answer it today
well, go
or
ahead
needs to
then.
come back. So in the presentation, they've talked about a discrepancy between the expected for-profit and the actual for-profit spaces. Can you speak to those numbers at all?
Yes, we are required by the province to maintain a 90-10% ratio of nonprofit to for-profit childcare. So that means 90% of our spaces must be not-for-profit and up to 10% can be for-profit childcare.
So on the numbers, I don't know who's got control of the presentation, but if somebody can put the chart up, whoever was running the presentation, they show the expected at 15%, which it was, is 275 short, and in April 25, it was 25 short. Can you speak to that discrepancy? What that, like, does that match your figures? And if it does,
Mr. Sweeney?
yeah, sorry. it's a little bit-
Councillor Shantz, if I could defer to the chair's recommendation that we could potentially bring some of these back. I don't want to have to get into a situation of trying to validate delegation statistics on the fly. If that would be amenable to council and to Councillor Shantz, that would be preferred by staff if we could.
Yeah,
Thanks.
I'm okay with that. Thanks.
Councilor Urbanovic?
Yeah, thank you. And I'm okay with staff bringing something back. I guess just in terms of what I'd be looking for is understanding the number of spots that have been allocated, the number of spots that we've actually filled and are operating currently, and the number that have been awarded but are going to open in some period of time, and what that period of time is. And then the question around the capital versus the operating dollars, and basically on the operating side, are we leaving any dollars on have we, or are we leaving any dollars on the table? Because I think it's important, and listen, I'd be the first one to say that I don't want to deal with, I don't want to miss the opportunity to deal with daycare deserts in the city of Kitchener, but at the same time, if those are going to take 18 months to open up, because that's what's happening with the partner that we're working with, we also want to make sure that we're not leaving dollars potentially on the table for 18 months that families could be using in our region. And I think we need to figure out a way then to better allocate that, and that can come back in the report. Thank you.
Okay, so there's agreement amongst council. We'll get this information back. Thank you for attending. Staff will bring information back to council, and we'll make sure that you're kept in the loop so that you're able to attend that meeting or receive a copy of that report as well. Okay, thank you. Oh, sorry.
Thank you, everybody.
Chair Redmond.
I want to thank the delegation too, and this is just dovetailing to what Councilor Ivanovic said. I'd also be interested when that report comes back to staff, from staff, what the long-term implication is of changing what we do now. Thank you.
Thank you. We are on to item 5.2. We have two delegations. Theo Yu, who has 5 minutes. You'd like to come to the podium, please? Welcome.
Good morning, everyone. My name is Theo Yu, and I am a community organizer from Waterloo. I am here to speak on the need for a bylaw decriminalizing public camping. I've lived in Kitchener-Waterloo my whole life, and like everyone else, I noticed the gradual rise in homelessness in the region and the sudden sharp increase that happened with the pandemic. The number of people sleeping rough is unlike anything I've ever seen, but it's not hard to see why. The 2024 point-in-time count found that between emergency shelters, motels, and transitional housing, there are just over 600 shelter beds in the region, but over 2,300 people struggling with homelessness. This is up from 1,100 in 2021 and projected to go over 3,000 by 2028. Quite frankly, the infrastructure to house all of these individuals does not exist and clearly is not going to anytime soon. I volunteer at the encampment at 100 Victoria Street, where a lot of people stay in the absence of shelter space and adequate housing support. Of course, there are plans for building a transit hub, which include that lot being turned over to Metrolinx and the residents being evicted by 2026. I ask you, what is the plan for these people? Some 30 to 50 people live at 100 Vic alone. I've watched as social workers help residents find space in the shelter system. I commend their work, but it is a slow process and decidedly outpaced by the arrival of new residents. Do you mean for these people to be simply scattered to the wind? The Ontario Superior Court has ruled that encampments cannot be evicted under trespassing bylaws if there is a lack of reasonably available and suitable alternative indoor spaces, and that doing so would be a violation of the Canadian Charter of Rights and Freedoms, rights to life, liberty, and security of the person. The fact of the matter is that around 43% of our homeless population lives completely outdoors due to the lack of shelter space. A public camping bylaw would honor the fact that these people have a right to shelter themselves how they see fit and deserve to not be criminalized for this simple act of self-preservation. I believe an acquaintance of mine, Andrew Reeves, has already spoken to the logistics of such legislation at the recent council meeting. I will not be reiterating his comments given the time constraint, but I would be happy to answer questions to that end. I ask that you direct staff to quickly draft such a bylaw in consultation with local unhoused folks, as well as volunteers and activists, such as the co-creators of the plan to end chronic homelessness. I thought it prudent to speak on this at committee, as I have heard that this is where public comment will be given due consideration. Thank you for your time.
Thank you for your presentation. I don't see any questions from council. Thank you for attending. We have a second delegation who just registered, Sky River Daisy. You have 3 minutes.
Thank you for your time this morning. I don't know where you got my middle name. I didn't put it in, I thought. Autofills. Good morning. I imagine that the job of regional council is to support the quality of life for the members of our community. I expect that you all take that very seriously. We must rethink laws against camping on public lands. Waterloo Region has an opportunity and an imperative to rethink regional support for its citizens. Today, I want to speak about the criminalization of homelessness, specifically the criminalization of camping on public lands. I'm going to skip the history lessons with respect to this region, and rather this is a moral and an ethical appeal. Like many of you, I am no longer young. I worked for a decade in childcare. For over 2 decades, I was a registered midwife working in this region, and I recently retired to complete my Master's of Social Work, and now spend a good deal of my time working with unhoused folks in this region. When we see tents and parks in our parks or people sleeping in doorways, we're not seeing criminals. We are seeing people who have been pushed out of housing systems that have been underfunded, neglected, and systematic for decades. Since the late 1900s, cancellation of social housing builds and downloading of housing responsibility to the municipalities has left no resources to support the housing crisis that these regions did not cause. We are aware that the increased mental health issues, addiction issues, the need for supportive housing and shelter spaces are desperate. The drug crisis that we once thought of as an American issue has been well embedded in our local communities. It is my understanding that Ontario stands alone among the provinces in placing social housing responsibilities almost solely at the municipal level. And yet we have one of the highest rates of housing needs in Canada. These facts reveal that the truth is currently a moral imperative. Criminalization of camps is not a solution. It is a violation of human dignity, especially when shelters are full and supportive housing is scarce and rents remain unaffordable. I believe this issue will escalate in the coming years if we follow the current trajectory of economic forecasting. I believe you have an opportunity to work with community members, to collaborate with end users and knowledgeable service providers to facilitate improved quality of life for many of our most vulnerable community members. If not to you, who is it that is going to raise up communities such as these? We must shift from punishment to compassion and from enforcement to investment. Public lands are desperately needed as an interim measure until housing is genuinely available. I plead with you to invest in housing first, supportive housing and non-market housing, to explore mechanisms to provide heat, running water, and toileting services consistently to those without in-residence housing, to understand that tents in parks are not the problem. Decades of public policy failure and inadequate investment are. I thank you for your time. References are available upon request, but paper, I don't have them here.
Thank you. I don't see any questions. Sky, thank you for attending.
Thank you.
Council, we're on to item number 6, the consent agenda. If you wish to remove an item from the consent agenda, please indicate so now. We'll only take questions on consent items unless your request removed on the regular agenda. Are there any items you wish to have removed from the consent agenda? Could I have a mover? Moved by Councillor Nowak, seconded by Councillor Gowing. Would you please use your e-scribe buttons to indicate your support. That is carried. To our regular agenda, item number 7, dealing with the Paramedic Services Master Plan, and I'd like to invite Chief Riches to make a presentation, and then part of the consultant will report as well. Welcome.
Good morning, Chair. Good morning, Council. Thank you for having us today. Online, I have Hannah Mays-Furnett from ORH, who will lead the bulk of the presentation, but I thought it is important to do some table setting for all of you. If you can go to the next slide, please. So this is in your consent agenda package, so hopefully you've had the chance to read this. We just wanted to table set where we're at in terms of performance in 2025, as that directly relates to our master plan for the next 10 years. And as you can see on the slide there are some real strong improvements that we're really, really proud of, by and large due to the support of Council, an evidence-based decision-making process that we employ, and the commitment and dedication of our frontline staff and our leadership staff, including creating and strengthening strong partnerships with hospitals and other system partners. In particular, ambulance offload time is a significant improvement. And to give you an example, for January 1st to June 30th of this year, we were at 42 minutes on the 90th percentile. But in 2024, for the same period, ambulance offload time was 105 minutes on the 90th percentile. And that's important to table set for you all because that is all time that goes directly back into our staff's ability to respond to calls and availability for our highest acuity patients. Similarly, I often get asked, when will we start to see a turn and improvement with things like what used to be called code reds, we now call code zeros. And for January to June of this year, we only had 4 code 0 events. And for the same period in 2024, there were 33. And for the entire year of 2023, there were 132 events of code 0. Mm-hmm. So I share that with you all as a bit of a success story to say this is what investment in paramedic services has resulted in terms of performance. Next slide, please. Before I turn it over to Hannah, I would like to connect how all this work connects to the Growing with Care strategic plan and our service performance. First of all, the implementation of the new master plan, if approved, does totally connect with the Growing with Care strategic plan and 3 of the 4 pillars. And it sets us up well for the next strategic planning cycle, which will occur, I'm assuming, in 2026 or 2027. And ORH, our consultant for this work, did include a review of the Growing with Care strategic plan as part of the look into previous master plans and other foundational documents. So this master plan that Hannah will go through with you supports current service performance with an intention towards ongoing quality improvement for the next 10 years. A couple of things to also let you know. Some people ask me, why are we doing a master plan now when we have an existing master plan? And the biggest reason for that is the existing master plan was developed pre-pandemic based on data that is now older. And as a result of doing the master plan now, we are actually going to see a cost savings in terms of investment in resources for 2026 and 2027, which is fairly significant given the fiscal pressures that all staff and councils are under. The other thing to make you aware of is we did have a steering group that helped guide this work, and it included representatives from Human Resources, Finance, Facilities, the Cambridge Fire Chief and WRPS, epidemiology and health analytics, and also transportation, just to make sure we had a rounded approach to guiding our consultant on this work. And it did also include some town hall engagement with frontline staff and our leadership team. So with that, I just set the table. I'm going to hand it over to Hannah to lead the rest of the presentation, and I'm here to answer questions once she's completed. Thank you.
Good morning. Can I check that my audio is coming through okay?
You're
Great.
coming through loud and clear.
So good morning, Chair and Councillors. Thank you, Chief, for the introduction. I think we can actually just skip forward 2 slides to the agenda for today. So in the slides this morning, I'm going to take you through a quick introduction to the core objectives that were put to ORH and our subcontractor ACE, and a quick introduction to who we actually are. Then the key findings of the analysis, as well as explaining at ORH what we mean when we say modelling, to give you context to the results that we've included in the master plan. We're going to look at what we think paramedic services demand is going to look like by 2035 and the impact if you effectively do nothing to address that. And then we've made a series of recommendations across frontline staffing and facilities, and also management and support services, with a proposed implementation plan over the next 10 years. Could I have the next slide, please? So why were ORH and ACE specifically asked to develop this updated master plan? So ORH are a consultancy firm. We're based in the UK. We use quantitative analysis and modelling techniques to support our clients, to help them operate in the most effective and efficient and resilient way. We work predominantly with emergency services, and in the last 15 years we've worked with quite a number of Ontario paramedic services specifically developing these kinds of master plans. And I have personally been involved in the majority of those reviews and was project manager for this master plan project. As I mentioned, we were supported by ACE, the Association of Ambulance Chief Executives. They are the representative body for UK paramedic services, but they also provide consultancy services with a focus on the more qualitative aspects of master plan reviews. Paul Woodrow was the lead consultant from ACE. Unfortunately, he couldn't join us today, but he has an extensive clinical and operational background, including working as Director of Operations at London Ambulance Service. So, we've got quite a wealth of experience across those areas. If I could have the next slide, please. So the high-level objective, of course, was to help paramedic services to develop an updated master plan for the next 10 years. There were 4 key areas of focus within that objective. So looking at service drivers, looking at service targets, evaluating the resource deployment model, and looking at optimising response. And there are 4 pillars to ORH and ACE's approach to achieving this objective. So we collect quantitative and qualitative data. We analyse that data to understand how the service has been and is currently operating. We then use predictive modelling to understand how the service can operate in the future. And alongside that, a lot of consultation, because data can't tell us everything about the lived experience of those working in the organisation. So all of that helps our clients to make better and evidence-based decisions. Could I get the next slide, please? Thank you. So the first step in developing a master plan, as I said, is to understand how the service has been operating historically. In this case, we collected data from 2019 through to 2024. If you could just click again to bring up the remainder of the points. Thank you. So the analysis we do is very detailed, as you will see if you've had a chance to digest the full written report alongside this presentation. But I've just included the very high level findings from that process here. So demand has been going up. There was significant growth in 2021 and 2022, with slower but still growth in 23 and 24. The performance targets were being met. There was a bit of a reduction in performance between 2019 and 2023, but that has improved again in 2024. And to the slides at the beginning from Chief Richards, has continued at that level in 2025. The average time that crews spend on a call, from mobilising to that call to kind of clearing once they've handed over the patient at hospital, was around 2 hours per incident. And around half of that was time spent at hospital, though again, per the points at the beginning of this from Chief Richards, that time spent at hospital, those offload delays have reduced in 2025. And the final couple of points on here are just over the last couple of years, the filled shift rate, so that is the percentage of frontline shifts that are actually put out on the road in comparison to the planned shifts, has been dropping to around about 90% in 2024. And utilisation of those shifts, so that's the kind of total time spent per job divided by that shift time on the road, was around 45% for patient transport units. If I could get the next slide, please. So we also completed a qualitative review of support and management services. So Chief Richards already alluded to some of this, but we visited Waterloo in person. We held interviews with a range of paramedic services and region of Waterloo staff, and we were supplied with various reports and documentation. As with the quantitative analysis, it's difficult to summarise the detail from the report into a single slide, but I've included the main themes here that we covered off. So looking at leadership and current organisational structure, healthcare strategy, clinical response model, frontline staffing and frontline management, clinical supervision, the community paramedicine programme, fleet and logistics, other regional support services, and emergency management. Can I have the next slide, please? So at ORH, we have in-house modelling tools to support the work that we do. The core one we use is called AMSIM, and we create a baseline position, in this case for 2025, in order to understand and compare the impacts of future changes. On the slide at the moment, there's a very faint screenshot of what the tool looks like in the background. If you could just click again to bring up the remainder of the slide. Thank you. So without going into too much detail, it's a complex simulation model that acts as a virtual replica of paramedic services operations. So it's effectively a safe environment for testing a wide range of what-if scenarios. So for example, what if demand increases? What if a new hospital opens? What if another ambulance is added at a station? And so on. And we do also have, alongside that, a location optimization tool called DCM that we use to help us find the best locations for stations. So when we're talking about modeling, we're talking about quite complex tools, not just, a spreadsheet that brings together different numbers, this really detailed kind of simulation and optimization tools. If I could have the next slide, please. So before we can identify what resources and facilities are required for the future, we first need to understand the impact of what we call a do-nothing scenario. So firstly, we make a projection of paramedic services demand using population demographic and housing development data. And the methodology that we use accounts for changes to population size, the ageing of population, and changes to the underlying demand rate, so the rate at which an average 1,000 people call for paramedic services. We created 3 projection scenarios, if you could just click again. So the core scenario was around predicting a growth of about 4.6% per year through to 2035, that there was a low growth and a high growth scenario considered as well. Context, the historical growth between 2019 and 2024, albeit a bit of a turbulent period because of COVID, was around 4.7%. So the do nothing scenario is about understanding what would happen if demand grew at that rate, that core rate of 4.6% per year, but nothing was done to offset the increasing demand. So no increases to resource levels, no changes to facility locations, and so on. So that's what's shown in the graph on the right-hand side for this core scenario. We've got the 80th percentile response times going from 2025 on the left through to 2035 on the right. One line for each of the municipalities, but the dashed black line is showing the overall region-wide performance. And that would worsen from around 9 minutes to around 15 minutes in 10 years' time. So clearly things would get a lot worse if you did nothing. If I could have the next slide, please. But you're obviously not going to do nothing, so we therefore need to identify what resources and facilities would be required to offset that demand, starting with facility requirements. So we evaluated how we think facilities should change given capacity, condition and coverage risks. But in short, the recommended facility configuration for the future involves retaining both of the hub sites and 7 of the existing kind of traditional stations, relocating 4 stations to more optimal locations, and adding 4 new sites, one of which is already planned, into areas of relatively poor coverage. So you can, from the map, we've shown the locations of the existing stations, the ones that we're suggesting to close and be relocated, and the additional stations. Also, to address capacity challenges, we are recommending that a 3rd hub should be built, and we have recommended that this could be in the Breslau area, given reasonable availability of land in that area and the expected longer-term growth beyond the 2035 horizon year of this review. If I could have the next slide, please. So it was agreed with the steering group that firstly, our goal for 2035 is that response performance should be no worse than it was in 2025. So in other words, that's our maintain performance scenario. And then we secondly set a goal of making sure that vehicle utilisation was also no worse than in 2025. In other words, a maintained utilisation scenario. So we've made a phased plan here that looks at what years should we introduce the facility changes, what years should we introduce physical new frontline vehicles, and when should we introduce new frontline staff. We also set a goal of improving relief capacity to allow for as close to 100% field shift rate as possible, rather than that 90% field shift rate that we were observing. So the relief amount is basically what covers staff absences, sickness, and so on. Historically, a 25% ratio was used. I know in recent enhancements that was up to 50%. We're aiming for a goal of 40% overall to make sure that we can get that 100% of planned shifts as close to as possible out on the road. That does mean, therefore, adding between 116 and 185 frontline staff between 2026 and 2035, depending on whether you're looking at the maintain performance scenario or the maintain utilisation scenario. The requirements in the first few years, 26 and 2027, are quite similar between the two scenarios. And as Chief Richards mentioned earlier, actually 2026 and 27 requirements are lower than the existing plan recommendations. If I could get the next slide, please. We've also made a similar phase plan for support and management services to ensure that frontline is sufficiently supported now and as it grows and evolves in the future. So, for example, we're recommending adopting a 20-to-1 ratio of frontline staff to operations superintendents. The existing master plan recommended a 25-to-1 ratio. Maintaining the existing ratio of frontline vehicles to logistics staff, but obviously as the frontline division grows, that we'll want to increase that and increase the logistical superintendent cover to 24/7. We're recommending that paramedic services seek agreement to place an operations superintendents into the dispatch centre to act as a system navigator, particularly as the service moves to a new dispatching system towards the end of this year. We've recommended adding a workforce planning lead role to support future resiliency, increasing quality assurance specialist capacity, and there are a range of other staff enhancements that we haven't necessarily given a defined phasing year, though they're split into kind of the first 5 years and the second 5 years, but really they should just be implemented as soon as is financially and operationally practical. You know, in a perfect world, they would all come online straight away, but we've got to obviously be mindful of the fiscal requirements for that. If I could get the next slide, please. So those frontline support and management resource enhancements, we recommended that these should be supplemented by a number of reviews and enabling strategies. So we've suggested looking at to embark on strategic discussions around the ownership of call answering, triage and dispatching functions. Alongside that, developing a new clinical response model, including expanding the CP programme. Looking at a short-term urban ERU expansion to maximise the usage of those in future, as well looking at enhancing treat and release protocols. Looking at a review of primary drivers for staff retention and absence, given that that absence rate has been growing over the last few years. Developing an advanced care paramedic bursary scheme and deployment plan. A review of IT systems and digital strategy. Developing service level agreements across support services, reviewing the scheduling function, and developing an options appraisal for clinical supervision and a leadership education and training programme. So the underlying themes here really are to provide the community with better access to the right services, to improve organisational resiliency, and to use data and technology really to work more efficiently. If I could just get the next slide. So just to summarise that quickly, so demand is projected to increase by overall 60% by 2035. If there's no additional frontline enhancements to address that, that does mean that 80th percentile response performance would worsen from 9 minutes to around 15 minutes. We've made a recommendation about the facility configuration, retaining both of the hub sites and the 7 existing stations, relocating 4 to more optimal sites and adding 4 new sites to address poor coverage areas. Also building a 3rd hub to address the future capacity challenges. This then means an increase of an additional 116 to 185 frontline full-time equivalent staff alongside a short-term expansion of the ERU programme, which can then be developed alongside the clinical strategy in future. The next slide, please. We've also made those recommendations about the support staff, the operations superintendents, full-time equivalent, the logistics staff, enhancing operations superintendents in the dispatch centre, adding QA specialists and a range of other supporting roles, in particular a workforce planning lead alongside many others. And all of those reviews that we talked about just a couple of slides ago. The community paramedicine programme is, already an integral part of the service, but really will be an integral part of clinical strategy for the future, and therefore will need to expand accordingly. One final thing to note just on the frontline full-time equivalent ask, we have aimed for a 40% relief rate to cover absences, but if through the workforce planning lead role and that review of drivers for absences to understand those, if the absence rate improves, then that will reduce the frontline full-time equivalent ask that's in here. So those 2 things are really vital. Thank you very much.
Thank you. Do you have any other comments you want to add to that, Chief Riches? We have some questions from council members.
Yeah, and thank you through you, Mr. Chair. Just as you know, the recommendation in the report is that council approves our new master plan and that is subject to the annual budget approvals process. So approving the plan does not mean that everything that's in the wish list gets approved automatically, although of course I would like that. But it does mean we'll use this master plan to essentially drive our asks in budget years on an annual basis. That's it. Thank you.
Understood. Councillor Hunick.
Thank you, through the chair. Oh, thank you, Karen. Thank you, through the chair. And thank you, Chief Riches, for the excellent appendices. I read every word and ate them up. I think what I want to impress upon my colleagues is that investment in paramedics is good value for money because it's a 50-50 cost share with the province. And I think the issue that stuck out to me the most is the problem of staff retention. It was surprising to me that for a paramedic to go from a PCP to an ACP is at personal expense. And so I wonder if you could speak to exactly how expensive is that? What would it take for us to develop an incentive program? And would that also be cost shared with the province if we implemented it?
Thank you, Councillor. Through you, Mr. Chair. That's a bit of a loaded question, except what I will say is we are working in the background on developing strategies to support, obviously, the development of staff who want to move from PCP to ACP. The cost is pretty significant for a paramedic to move to the ACP program as it's a third year in the current college system, and the tuition is very, very expensive in the around $15,000 to $20,000 range for the year. And then there's the additional time on task when you're not on the road making income and those types of things. So, and there are a number of college programs throughout the province. Unfortunately, right now there is the close college, but in my discussions with our partner at Conestoga College, I know that they are looking to implement an ACP program at Conestoga, and once they do, then I think it will be prudent upon me and my leadership team to work with Conestoga to how do we create a formal partnership with them that is properly supported both from a support of staff and then a funding perspective, as taking into account fiscal challenges that we're all dealing with. But we are working on that kind of strategy, so I'll have more to come on that.
Great, thank you.
Councillor Rodriguez.
That came quick. Thank you, Mr. Chair, and thanks, Chief, for being here. So to build on Councillor Hunick, I think great value for money is also in the community paramedicine program, notwithstanding some of the challenges that are acknowledged in the report. Could you see it as it is expanded and hopefully fully funded, in future years? Could you see that impacting the recommendations in terms of future FTEs or other roles, or if there is a big change in that program, could it impact what you're recommending today?
Thank you, and through you, Mr. Chair. In short, yes. I think if we continue to expand the community paramedicine program, and as I'll remind Council that the community paramedicine program is 100% funded by the province through both the Ministry of Long-Term Care and Ontario Health, Ministry of Health. As we expand that program and provide more upstream solutions in supporting patients in the community so that they don't need to call 911, the hopeful result is that the demand on the 911 services drops. So my suggestion would be that in 4 or 5 years' time, we do a reevaluation of the master plan where it's at versus the data and just do a data refresh. That is common in a master planning cycle of 10 years. This was announced by the province in August. I'm not sure if everybody on council caught it, but the province did announce that our funding for from the Ministry of Long-Term Care is going from annualized grant funding to permanent base funding. So that'll be taking effect starting April 1st, 2026. What we don't know yet is what our funding level is. Will it be the same that we've received on an annual basis, or will it be adjusted either up or down? But obviously, if the province has recognized that community paramedicine is here to stay and is permanent, that clearly allows us on a long-term basis to be more strategic in how we implement community paramedicine. It's always been my vision. Right now, we're at about a 90% 911 response, 10% community paramedicine. It's always been my vision to change that ratio to about a 70-30 ratio or 75-25. Theory being you invest on that 25% of community paramedicine. Hopefully you don't need as much resources on the 911 response. I will remind council though that there are some things that community paramedicine can never avoid or can never prevent. So there will still be significant traumas in the community, heart attacks, strokes, which was what originally ambulance services were designed to respond to. And over time, we've been still responding to those and all these other kind of more complex continuing care issues.
Thanks. I did my own little recon at the hospital this weekend and poked around to see who was, where they might be seeing some folks who could be served by other programs. On the sort of capital side of things, I'm particularly interested in how we use our land, how we buy land, how we share land, and how we achieve multiple goals on land. So, to say, and appreciated some context that conversations we had prior to the meeting about, co-location of uses, and I would, encourage that to continue to happen where it's appropriate and viable, both with other regional services or area municipal services, so that we are able to make the best use of that land. And some of the stations that you're talking about in the plan are quite urban, and they're not out beside the dump with quite a bit of land. So, I think if they're, when we're talking about a much more urban setting, how can we achieve multiple benefits? And I hope we can get there with that. And then I think just, so I would just say that. And then my last question is just in terms of the Williamsburg site that's shown, is that contemplated to capture all of sort of Southwest Kitchener over the next 10 years? Or is that sort of, what do you see that capturing right now?
Thank you for your question. The Williamsburg site, and Hannah may want to jump in here, but the Williamsburg site, we're calling it Williamsburg in this plan, but it was already a site identified, or that location was identified in the existing master plan to support South Kitchener. It's kind of you try and create a recipe that works for response for the entire region and also local communities. And certainly it's been long identified that area of Kitchener needs a facility in order to respond strong response times for that area. But it's also important to point out that if we build the facilities in the right locations, then it will support responses like on a kind of a overlapping event across areas. Because if I have one vehicle at the new Williamsburg site and one vehicle at the next station, as soon as that one of those vehicles gets a call, that vehicle, the second vehicle I just mentioned, is now covering the whole area. So we want to make sure we're overlapping properly. And I don't know if you want to comment on the Williamsburg site specifically in terms of your recommendation.
Yeah, thank you, Chief, and through you, Chair, to the Councillor. Yeah, I would echo the Chief's comments. I think, we did some location optimization that identified that as the kind of most optimal location for that area of Kitchener, and particularly it was, identified as an area of a bit more of a gap in response performance coverage. So it would predominantly be servicing that area, definitely. But yes, as the Chief says, it would be also supporting other areas as it overlaps. And we were hearing and seeing in the data about the kind of drives between the existing stations and also the expected ongoing housing development growth in that area. So that's why it was quite a key location for our recommendations.
Thanks, Chief, and thanks, Anna.
Good timing on show and tell, Councillor Rodriguez. Thank you. Councillor Wolf.
Through Mr. Chair. Thank you for the presentation, and thank you for some very interesting reading over the weekend. Your master plan is very detailed and well done. As I was reading, I came up with a few questions. One, I was very impressed with your offload delays decline by 70%. And could you maybe explain why you think that happened?
Yes, through you, Mr. Chair. I appreciate the question. This is the result, I believe, of we prioritize it as a leadership team. We meet with each of our 3 hospitals every 2 weeks. Sometimes it includes the vice president of the hospital and myself. Other times it includes more operational leaders. And really the biggest driver was that at the Waterloo Regional Health Network in particular, senior executive, their vice president of clinical services, decided to champion this work and made it, and what the biggest driver change was that they made ED ambulance offload time performance data a whole hospital metrics. So it was not just something that was in the emergency department and only the emergency department worried about it. The entire leadership team at Wren supported it and led it. The other thing is the Ministry of Health and Ontario Health is when our data was not strong in ambulance offload time, brought us to task on quarterly meetings to say, hey, you got to get your house in order. And as many people on council have heard me say, both in public meetings and also in private conversations, ambulance offload time is not something that paramedic services in isolation can solve. It is a symptom of a larger patient flow issue at the hospitals. And so, I think I would close by just saying, when you have hospital leadership who believes that that's an important metric to improve, you start to see results. And we've seen results at all 3 hospitals, and in particular at the 2 Wren sites. Really, they've been able to maintain around a 30 minute on the 90th percentile for the last 6 to 8 months. And I believe that, first of all, we are seeing better response times as a result, a less end of shift overtime for our staff as a result. And I think qualitatively, our staff are experiencing better work days because of it. But that is probably the biggest driver, is just that people prioritized it and it became a real important thing. The last thing I would say also is that the province said this is an important metric, hospitals, you have to pay attention, and our local hospitals did.
Thank you. And I have a couple of others, but I'll just go for one. The clinical response model. Can you talk a little bit about the importance of that? Because, again, I think the public tends to see you from A to B,
right,
and you're so much more than that.
Yeah, appreciate your question, and through you, Mr. Chair. So the hope for a clinical response model is that we, as we mentioned, and you'll hear next month when I come to talk to you about MPDS, the new dispatch system, it's all about ensuring the right resource is going to the right patient for the right reason at the right time. And so a clinical response model that's foundational in that element, and it's making sure the experts to make sure that they're delivering care.
Career pathways as well for paramedic, frontline paramedics who can be in those positions where they're needing kind of more of those skills to make this a more even more attractive service to work for. Thank you.
Thank you.
Councillor James.
Thank you, through you, Chair. Thank you to the team and to the consultants. This is a very thorough, well-detailed plan, and I want to say that it aligns with our strategic plan priorities, which I found throughout. It also shows a strong commitment to our partnerships and long-term planning. So I will say, as a researcher, I appreciate the qualitative and quantitative aspects of this as well. Part of my question aligned with Councillor Rodriguez. I just want to expand on the relocation, those optimal locations. Speaking of some...
And I'm really just curious on how that plays into it, as well as looking then at the overlay of our primary care access. Our townships are the ones that have the least access to primary care. Wilmot residents, for example, over 25% of my residents don't have a connection to a primary care, which means that often they wind up in our hospitals in acute care, even if it's not the appropriate place. So just wondering how that data played into what information you guys are proposing.
Thank you, through you, Mr. Chair. That's a very detailed question. I will start and then kick it off to Hannah. The first thing I'll say about primary care, obviously, people who are not attached to primary care is a concern for any community health care group, including us as in paramedic services. And certainly, we are aware that the rural townships, from a primary care perspective, require probably some more support and advocacy. I do think that this is specifically for the rural townships, community paramedicine can play a really, really large role, and that's where we see a lot of the expansion happening. The advantage to that is community paramedicine doesn't necessarily always need a bricks and mortar facility to deliver care, because it's mobile health care in and of itself. With respect, before I kick it off to Hannah, with respect to the current master plan and the Elmira station, once fully realized, can also support Wellesley Township, as you know, and you brought up the border perspective. Certainly, supporting the rural townships is important to us for the healthcare equity lens, but the other thing that we always have to balance is the likelihood of calls actually occurring in those areas, because call volume is quite low in the rural townships, as you all know. It's not to say we don't want to support those calls, because if they're sick, they need us. But it's a bit of a balancing act in that regard. But I'll kick it off to Hannah related to your question about the DCM modeling.
Yeah, thank you, Chief, and through you, Chair. So yes, the projections that we've made about demand take into account not only the increase in population, but the aging population. And looking at that, how that is different for the different municipalities. So we haven't just looked at the region of Waterloo as a whole, we have made projections for each individual municipality based on that data. So we know, for example, that although the 75 and plus overpopulation accounts for around 7% of population, it accounts for around 30% of incidents that paramedic services respond to. So it has to form part of our projections because we know it's such a driver of demand. So when we've built those simulation and optimization models with the projections in, it has been done at quite a detailed geographical level. And we're also provided with some traffic zone population projections, which is even more granular than the municipalities themselves. When we've looked at where locations should be and where resources should be in the future, I would echo, that it is going to, we're not going to see that do nothing scenario. We've made sure that this scenario allows for current performance to be maintained in every single municipality.
And if I may just add, this is where, again, through another councillor's question, I think 4 or 5 years, a review of the data and updating our statistics becomes really, really important, because hopefully we see the results that the master plan is projecting to achieve. But if it's not, we'll need to pivot and kind of readjust our strategy.
Great. And a follow-up, if I may. Thank you for that. My other question is actually about how this plays into the new hospital and the new hospital location. If you could just speak to that on a bit more of a broad scale, because I know that'll be towards the end of this plan. We'll see that opening.
Yeah, for sure. And through you, Mr. Chair, and thank you for the question. One of the reasons, there was a number of reasons we decided through and got support to update our master plan now. And one of the drivers, not the only driver, but one of the drivers for doing it now is the knowledge of the new hospital and where it's going to be located. So certainly right now what we enjoy are 3 busy emergency departments, 2 very close to each other, and then 1 in Cambridge. And certainly when you remove one of those emergency departments and move it further north in the region, that adjusts everything from your response times to your transport times to those facilities and hospitals. We're in regular consultation with REN about the hospital redevelopment project and making sure that our needs are met from a response time perspective. The other thing I would tell you is that if, and I know REN's not recommending this, but if both of those, if the Queens and Midtown sites were both to close as emergency departments and then they were just to open the new facility, the actual knock-on effect would be on the Cambridge site for us. Because legislation requires that your highest acuity patients, what we call CTAS 1s and 2s, go to the closest facility, that means that if there's a call in the current area where Midtown and Queens is, and those were to close, the next closest hospital is Cambridge, even where the new site is. So that was all part of this, and maybe Hannah can speak more to what we saw the new hospital opening did to performance and how we adjusted it.
Yeah, thank you, Chief, through you, Chair. Yeah, so in the results we've presented today, in the slides, we've not really touched upon the hospital relocation much, but it is included in the report as part of what we call sensitivity modelling, because it was at the tail end of the horizon year and because there's still some, logistics to be worked out as to exactly, what's going to stay open. It's kind of kept as that separate sensitivity modelling. But yes, we found actually that, obviously there's going to be changes to the hospital flows, and there was a slight reduction in Kitchener response performance and a slight improvement in Waterloo response performance, but actually the changes in response performance weren't huge. It wasn't like suddenly you're not meeting targets anymore, though that was under the scenario in which they don't both close. So if they both close, then that is, as the Chief says, a bigger knock-on effect. And as that becomes a bit more fleshed out on the master plan in 5 years, hopefully that information will be clearer and we can do an even more detailed evaluation of that.
Councillor Gowing.
Through you, Chair. Councillor Solomon took some of my thunder here, so I was going to look at the rural areas as well as the aging population. But my next question is based around the absenteeism. You mention it in here. What strategies are you looking at to reduce the absenteeism?
So that's part of the recommendation in the master plan in terms of doing a formalized review of the drivers of staff absenteeism and retention. I can say to you that Certainly, WSIB approved lost time claims are a significant driver. It goes without saying, but it's important for me to say it, that our staff are exposed to significant traumatic events every day. That's what they do every day. And as a result, there are times when those staff need to be off work in order to heal from what they've experienced. So certainly we want to ensure that we have an appropriate mental health strategy, which Council did support the initiation of in 2024, and see that work continue. And then really it's about right-sizing the relief pool of staff to our deployment commitments. So as Hannah mentioned earlier in the presentation, originally the assumption was that we needed essentially 25% of staff to support the 100% of staff that are full-time essentially. So if you put 4 staff on a 12-hour ambulance for 7 days a week, you would need a 5th staff member to cover all the different reasons they can't be at work, whether it's vacation time, training time, WSIB, sick time, or whatever. We pushed in the last couple of years to make that relief rate 50%, so now 2 relief staff for every 4. And then Hannah has recommended that, or H has recommended, excuse me, we're at about a 40% relief rate. So I think it's a combination of things. One, certainly the mental health toll on our staff is a significant driver of absenteeism. Secondly, the relief rate calculations that we used up until recently was not enough to keep up with our deployment commitments, if that makes any sense, because what paramedic services traditionally do in Ontario is for every ambulance we're committed to deploying, if someone can't be at work that day, we try and fill that shift so that there isn't a downstaff. What we've experienced in the last couple of years is staffing levels not staying with the different reasons people can be off work. And as I mentioned, there's a lot of different reasons: sick time, WSIB, vacation time, the all-important training time to make sure our staff are ready to respond to all calls, things like that.
Councillor Schatz?
Or sorry.
Thank you. I just wanted to quickly add that what we're aiming for in terms of is consistent with what is also needed across ambulance services in Ontario. So we are not different in that respect. Thank you.
Councillor Schatz?
Thank you. Through you, Chair to Chief. I always talk about offload delays, so yay. I'm really happy to see after almost 11 years that it's starting to pay off. So my question is a little bit related to that. We've talked about the ability to drop off at clinics or specific housing areas, and I wonder if that's moving forward, how that's going, if you see any future changes or how that might affect the plan. And then my follow-up question is probably to Dr. Wong about advocacy, and as we make these improvements and as we see improvements to the whole system, is there a place for advocacy for reallocating funding? That we might be able to get more funding because of overall efficiencies in the system.
Through you, Mr. Chair, I'll take a stab at your first question. And obviously, we're really, really pleased with the ambulance offload time improvement as well. With respect to, you're talking about like an alternate destination strategy, or we call it the patient care models, which allows for treat and release, treat and refer, and alternate destinations. Certainly, we see that forming a large component of a clinical response model or a clinical care strategy. Having been a longtime paramedic myself before I moved into leadership, nothing frustrated me more than the only answer I had for a patient, which is just to take them to the hospital, and then they waited for hours at the hospital. So giving our staff some more tools by which to provide more appropriate, we'll call it disposition decisions, like what happens to the patient at the end of the call, I think becomes really, really important. We've done a lot of work, both with public health and our team and other community partners, about trying to set up an alternate destination clinic for mental health and addictions cohorted patients specifically. We already do an alternate destination for hospice for palliative care patients, which has been successful, although it's a very, very small number of the total patients we support. And certainly we do see a time down the road where lower acuity patients maybe don't get taken to hospital, they get taken to a hospital supported urgent care or something like that. The province seems really, really keen on expanding these models. And in order for us to achieve those models, we have to make sure certain conditions for success are met and then apply to the province for approval under those models. And certainly, I think I would close with saying that the calls are going to come into 911, and it's about how we manage the 911 call once it comes in that becomes really key to driving success. So that could be, as Hannah pointed out, hear and treat, so that we don't send a resource at all. A clinician says at the dispatch center, no, you don't need to go to the emergency department, but we'll send you a taxi to go see your primary care physician. I've made an appointment for you for 10 a.m. tomorrow morning. Those are the types of things that are done in the UK and Australia. So there's one example. And then the other example are alternate tools such as treat and refer, treat and release, and alternate destination. And certainly with the new hospital coming online, as people know, I think their plan is in 2032 when they build the new site, it will immediately open as an urgent care for the first 2 years. We will work with our hospitals that even though that's not an emergency department, can we take our lower acuity patients there to help take pressure off the existing emergency departments?
And in response to your second question, Councillor Chance, Council has supported our efforts to advocate for more funding to our mental health and addictions providers such that they can establish clinics where paramedic services can transport patients. They can't do that unless in terms of our overall expansion of services that we've seen over the last few years because of need and that Council has supported as well. The province has continued to fund 50% of that growth as well, which is very positive for our community. And certainly, leadership and paramedic services and myself would continue to provide Council information about opportunities for advocacy that will come in the future in order to try to achieve some of those objectives of not only, continued and improving service, but also cost efficiency. Thank you.
Councillor Craig.
Well, thank you, Mr. Chair. First of all, I just want to compliment all the people involved in the report. It's an excellent report. It bodes well for the future in terms of where we're going and dealing with the issues of the future. The thing that always stands out, of course, and I come back to some of my friends here on council, dealing with the rural areas. And it's always the same. It doesn't seem to really significantly improve. We have other regions in the province of Ontario that have rural areas. Are they doing anything innovative or are they comparable to what we're seeing in terms of response times?
Thank you, Councillor Craig, through you, Mr. Chair. In terms of innovation, all paramedic services are subject to the same legislative requirements. And so the ability to innovate is, I would say, influenced by that, if I may. I was trying to come up with a different word, didn't really work. So, however, all that being said, if you're a paramedic service that only supports rural communities, then how you deploy your resources might look different than in a mixed model like we have. We are a mixed urban and rural paramedic service, so we have to come up with one overarching strategy that essentially has two pillars, one for urban, one for rural, and they do influence each other. I think we're in a good position if this master plan gets approved to really, when the time is ripe for innovation and implementing innovative solutions, we'll be ready to do so. There's a lot of work that's happening through myself and other leadership colleagues across the province to push the province for legislative reform under the Ambulance Act and things like that, that will hopefully create more of an incubator for innovation to especially support rural areas. But as you point out, Councillor Craig, there are other communities of rural areas, and speaking to my colleagues from Northern Ontario, they have a whole different set of conditions in, the far north of Ontario than we have here in southern Ontario. So we need to make sure that there can be local innovations to support that. And there are some, I wouldn't call it restrictions, but there are legislative things we all must meet, and sometimes that can get in the way of innovation.
So understanding all of that, in some of these other communities in Northern Ontario that are specific to rural areas, do they have better response times?
I think I don't have all the data right in front of me.
No, I realize that.
But I would say that some have better, some have the same, and some have significantly higher response times.
So we can learn from some of the better ones.
For sure.
Okay.
And I can, if I may, Chair, I can tell you that we're on a regular basis working with other paramedic services to learn what they do best and bring it into our area. And similarly, other paramedic services reach out to us and we share our information. So there's a real community of practice involved in the province.
I'm not trying to poke holes in what you're doing, okay?
Yep.
I have to ask these questions because they always stand out. And of course, the other one you can expect from me is the performance response times of the three cities, where Cambridge is always on the slower times. I bring it up consistently, and consistently nothing changes. What would you propose to bring Cambridge up to speed with the other two municipalities in terms of approximate response times?
Thank you, and through you, Mr. Chair, I did expect this question from you, Councillor Craig. I would say that one of the biggest drivers of response time challenges in the Cambridge area is the ambulance offload times at Cambridge Memorial. So although we are seeing overall significant improvement across all three hospitals' ambulance offload time, with respect to, if you isolate the hospitals out, as an example, from January to June of this year, the Midtown site was 37 minutes on the 90th percentile. The Queens site was 33 minutes on the 90th, but Cambridge Memorial was 68 minutes on the 90th percentile. So it's almost double what our other hospitals experience. I will tell you that that is a significant improvement from 2024. So Cambridge is working to solve the problem. But when you have resources stuck in hospitals, even though those resources are in community, it's hard to get them out of the hospitals to respond to calls in the Cambridge area. So it's not the only reason for that, but it is a significant driver of those response times.
And I appreciate the candidness, okay?
Yeah.
The last question, if I may, Mr. Chair, through you.
If I may, Dr. Wong would like to respond to something.
If I could just add something about response times in rural or further communities that are further away from urban cores and that are less dense. It is always going to be a factor in terms of response times, how densely, how many calls come up from a certain area and how far away those areas are from where the majority of calls are. The way that ambulance service works in Ontario, even though they're planned within municipal boundaries, if there was an ambulance service serving only a rural area and there were more calls that were in a neighboring urban area, then those resources in the rural area would be deployed across boundaries to the urban area. Sorry, yes, exactly, to the urban area. And so they would not stay in the rural area. So there are factors related to where, because the system in Ontario, understandably and I think appropriately, will dispatch ambulances to where they are most required. Those ambulances, even if they start in rural areas, if there are not a lot of calls, and most of the calls are in some other urban area, those ambulances will be dispatched to those areas. And so there are always factors that make it that you cannot have equal times based on municipal boundaries. You can improve response times in all areas, including rural areas, when you have things such as increased resources, as Chief Riches and Hannah explained earlier about if you have more resources, then they won't get pulled from the rural areas to service urban areas as much, as well as other innovative new things that we will continue to look at to see if there are other ways to ensure that we provide the best response times possible for people living in areas that are further from where most of the calls are. So I just wanted to just sort of provide those pieces of information so that it can be understood why response times cannot be equal between rural and urban and cannot be equal necessarily between cities either, just based on municipal boundaries. Thanks.
Well, Mr. Chair, if I may, just to conclude, if there are other areas in rural Ontario that have better response times than what we're seeing here, I'm wondering if we could have a further investigation of what they're doing and how it may be perhaps transported here as a model.
Absolutely. Thank you for that suggestion.
Mr. Chair, I see Hannah's hand is up, just so you're aware.
Okay, we have two more requests for speakers, Councillor McCabe and Chair Redmond, and then I'm wondering if we can bring this to a conclusion so that we're on time for the next group. Councillor McCabe.
Thank you so much, and I appreciate the discussion. And I may have missed a little bit of your answers and presentation while I was in transit, so forgive me. But and most of my questions have been asked, but I do want to just touch on how this connects or how the alternative destination clinic piece is connected to this, or hopefully will be connected to it. And I also just wanted to underscore the need, and I'm glad to hear that the chair at the recent AMO conference had a delegation about this with provincial representatives, because, as we've all said to the province on many occasions in a variety of meetings, the growth that we're experiencing requires provincial services to be increased and directed to communities like ours that are experiencing that. So I'm glad to hear that. I'm also just curious how what you're discussing really fits into the coordinated communication center that the WRPS has proposed, and what that may do to improve response times, because my understanding is that with the collaboration that they're looking for out of that coordinated communication center, and being able to say, you don't need police, you need paramedics, or you need fire, you don't, that kind of stuff. Just how that could really improve our response times. And then the other question, and I did hear Councillor Rodriguez ask it, but I really want to underscore, where there are possibilities for co-locating with local fire services, as well as police stations, but other, our recreation centers, other public infrastructure, that whether we're building it as a local municipality or a regional municipality, and then what the possibility is to include in that, what the possibility is for some housing on top of those locations as well. So those are my questions. And I just a final comment, just to underscore what you were just saying, Dr. Wong, about response times. I mean, I think part of what we need to also keep in mind is the more that municipalities, expand and sprawl, the more impact it's going to have to our response times. I'm not suggesting our rural communities are sprawl. They already exist. But the more that we go outside of, say, the countryside line, or we go into greenfield versus intensification, it is going to have an impact on response times. And we just have to, if that's the choices that we're making, we have to know that there's a trade-off there. So thank you.
Thank you. I will try and address each of your questions. The first one related to alternate destinations is more connected to our clinical strategy or clinical response model. As I mentioned before, if we have other better suited options in which to transfer care of a 911 patient to another more suitable resource, whether it's an in-community or a treat and refer type model, certainly that informs that part of the plan in terms of what to do with the call once it comes in. With respect to the Public Safety Communication Center, which I think is what you were referring to, Certainly, Chief Crowell and myself and others are currently in discussions with the Ministry of Health, advocating that they take the current Cambridge Central Ambulance Communication Centre, which is located on Writers Drive in Cambridge, and move it into the Public Safety Communications Centre as a preferred tenant. The theory behind that is by co-locating those resources, then when it comes to certain types of calls, high acuity incidents, multi-patient incidents, we can provide a better, more coordinated response in that regard. So that work continues. I will point out to council that ambulance dispatch in our community and in most communities across the province is 100% funded by the province and directly operated by the province. So that's an important distinction. There are a couple of communities in Ontario that operate their dispatch center and then receive the 100% funding from the province, and that's specifically in Toronto, Ottawa, and Niagara. But in our current region and most other regions, it's a directly operated central ambulance communication center by the province. So the staff are theirs as well. And then with respect to co-location, certainly we're always looking for innovative ways to partner on the ever important land acquisition challenges that there are. And as I'm currently involved in a project in North Waterloo to look at the feasibility of whether we can co-locate multiple emergency services and then perhaps other community services and or housing. And I'm not an expert in how to knit all that together, but there are architects and planners who can put that all together and say, yes, this is feasible, or no, this isn't. So we're always in paramedic services looking for innovative ways to get the station where we need it, whether that means partnership with other organizations or not, whatever it looks like. Thank you.
Chair Redmond. Chair Redmond.
Sorry. I was having a side conversation here. Mr. Chair, I'm going to suggest that we call the question. I think it's a very thorough airing, and just as a sort of point of reference, the chief is very good about coming to successive AMO meetings to continue to put forward a lot of the innovation in the alternative destination, as is Chief Crowell. So we continue to work in common cause.
Because you're calling the question, I have Councillor James to move it. Did you say you're seconding it? Okay. If I may, though, have a question as chair.
You're allowed.
One of your comments was, you said you think most people know with the new hospital there's going to be an urgent care clinic. I don't know that. What could you expand on that?
My understanding is there's a phased approach, and I'm by no means the expert on this, but there's a phased approach to how the hospital will open, and the first phase of the new site will be to stand up some clinical care services in I'll call it an urgent care model, with the long-term goal, not even long-term, phase 2, meaning it turns from an urgent care to an emergency department, that's all, which is very, very common across the province when they build new hospitals, because they've got to soft launch certain clinical services, if that makes any sense.
Okay. So it's not going to be something freestanding, separate. It's going to be integrated into it
Correct.
eventually.
Yeah.
Good.
Yeah.
Okay. All right. We move by Councillor James, seconded by Councillor Redmond, or by Chair Redmond. Use your e-scribe buttons to indicate your support. That is carried. Thank you for a very, very detailed presentation, both from our external support and Chief Richards. Thank you very, very much. Good roadmap going forward. Number 8, Council Committee tracking. There is none. Is there any other business? Councillor Foxton.
Thank you. Just 2 brief announcements. I left a brochure on everybody's desk. It's the 116th annual plowing match. It's really something to see because some of them bring their horses and they plow with the horses, and then you see the tractors and that. It's an interesting day. If you can make it out to see it, that would be great. And the other thing is that I'm going to an event, and they've asked me to share it with you, and it's the 83rd anniversary of the Women's Royal Canadian Naval Service Training Establishment, HMCAS, Conestoga. It was based in Training Centre for Women of the Royal Canadian Naval Services, established in 1942, and the goal of those women was to take on crucial non-combative roles and marked the first time that women served the Canadian Navy in any capacity other than nursing. It's a wonderful organization, a wonderful group, and across Canada, it's where the Wren statue is in Cambridge, downtown Galt. So I will forward this to all of council. They can see that and decide if they'd like to attend, and they can respond accordingly. Thank you.
Thank you. Our next meeting is October the 7th. We're ready to adjourn. If somebody's prepared to move, Councillor Gowing, seconded by Councillor Wolf. Use your e-scribe buttons to indicate your support. No. Okay, that is. Okay, we'll have a quick 5-minute transition, not a break. Stay close by.